So let's give a nice warm welcome to both Dr. Hicks and Dr.
Well, thank y'all for having me. I'm Tim Hicks. I heard that there are 2 hygienists or hygiene students. All right, great. I'm a dentist by trade, although the Indian Health Service has taken me into a lot of different areas outside of dentistry. We're going to both tag team this presentation, and then at the end we're going to have sort of a question and answer thing that's unrehearsed. I'm going to be asking him questions because I think you will most identify with John since he's been a student here. We've hosted 5 or 6 interns from ETSU in the last 4 years. So anyway, let's go ahead and start. First of all, I want to say that we are one of the agencies of the Department of Health and Human Services. Our director, Dr. Yvette Rubidoux, is a presidential appointee. There are 566 federally recognized tribes in the United States. By federally recognized, there's a certain minimum requirement that Native American tribes have to undergo to become federally recognized. In the state of Tennessee, there are none. There are some state-recognized tribes. Those 566 tribes are spread out across 35 states with an estimated population of 2.1 million Native Americans and Alaska Natives. And we have 612 different facilities, and we have a whole range of facilities. We have more than 30 hospitals spread out across the country. We have urban centers. In a minute I'll tell you about the Nashville area, but in our region there are urban centers in New York City, Baltimore, and Boston. We have outpatient facilities that are fully staffed with medical, dental, optometry, behavioral health, etc., pharmacy. And then we have rural Alaska village clinics and health stations in the rural western U.S. Oh, see, I went the wrong way. I just want to show this picture. This is a picture from the 1940s, and it shows several things. I don't know how well you can see it, but there's an elderly Native American woman laying down in her home, which is covered, the floor is a dirt floor, and she's being tended to by a healthcare worker. This is a traditional healer. And a couple interesting things about this. This isn't that long ago in the 1940s, and a lot of Native Americans still lived in this way. Second of all, the traditional medicine aspect is still part of the Indian Health Service. So, you know, we teach both Western medicine and some holistic medicine. So right now I'm going to turn it over to John, who's going to talk about health disparities.
So some of the...
You went the wrong way too.
Yeah, of course. So some of the things I want to talk about are some of the challenges that Indian country are really facing. So some of the things that we, as the Indian Health Service, really want to focus on. So I'm going to go through a couple of these. As you can see, the life expectancy is lower in Indian country, about four years. Again, let's see. Some of the leading causes of death for Native Americans. There's the top 5 over here, and you'll see one of the interesting ones, I think, is this unintentional injuries, which includes alcohol-related or motor vehicle crashes. Okay, let's see. Gee, it's still getting it wrong. And again, to emphasize this, you'll see that how the difference in how injuries are so common in Indian country as compared to some infectious diseases and other diseases. And also, diabetes is a really prevalent and severe problem in Native Americans. We're a little over 2 times higher likelihood of having disease or diabetes. And I don't know if you can see this right here.
They can on the other screen.
Okay. So the death rate attributable to diabetes is also greater in Native Americans, as is almost all your common stats that you follow in regards to diabetes. This is an interesting and very troubling stat that was developed, and is that 1 in 3 Native American women will be raped at some point in her life. So it's very troubling. And the general population is also troubling. 1 in 5 women will also be raped. So a major issue. And this is also interesting because it illustrates the funding and the amount of money that is invested in health care to Native Americans as compared to other populations. So you'll see that federal prison inmates receive larger funding per capita than Native Americans. And infectious diseases, there's still today every now and then some outbreaks of some of your common infectious diseases in Indian country, similar to all of the U.S. But I wanted to show here some of the initiatives that the IHS is sponsoring. One of the major ones is flu and the vaccination, and also getting tested for HIV is also a major push in Indian Health Service, and also one that I don't have illustrated here is regarding oral health. Sometimes we forget about oral health whenever we talk about health promotion and prevention. And I've been fortunate enough to work with Dr. Hicks on a national initiative that focuses on cavities or caries in early children, 0 to 5-year-olds, which has really shown some great outcomes and some evidence that improving access will help decrease the prevalence of caries. And actually, the Indian Health Service has the largest dental sealant program in the world, and provides 300,000 sealants. And now I'm going to turn it back over to Dr. Hicks to talk about the Nashville area. So here's.
Okay, I'm not going to read all of this other than to say our mission is interesting in that it's to raise the physical, mental, social, and spiritual health of American Indians, Alaska Natives to the highest level. So there is the spiritual component, which brings in traditional medicine, and as you are all learning about in public health, you can't address just the health problem. You have to address the social determinants, and as much as we can control, we're trying to do some of that. The Indian Health Service is divided into 12 different regions, or areas as we call them, and each area is named after either where the administrative, the city where the administrative headquarters is, or the state where it is, with the exception of the Navajo area, which is named after the Navajo Nation, which is the largest Native American tribe in the U.S. at 360,000 people. The Nashville area is the area we represent, and we're headquartered in Nashville, Tennessee, a short 4.5-hour drive away, which I have learned this morning. Once again, for a third time. But those are the different areas. Obviously, if you know anything about Native Americans, the largest concentration of Native Americans is in Oklahoma and the far west in New Mexico and Arizona. The largest number of Alaska Natives are in Alaska. Here in our area, all these little dots represent health care facilities. So even though we so-called cover 35 states, what that means is if we get a patient calling us from Illinois a Native American patient needing care, we have to try to find a facility for them to go to. And obviously there's no facility in Illinois, so we have to direct them to one of these other red dots. But we are located in 14 different states across the eastern and southeastern U.S. Some of these, we have 2 hospitals, one in Choctaw, Mississippi, and one in, Cherokee, North Carolina. We have 31 ambulatory health clinics. And John and I, when we were looking at this slide and discussing it, we kept coming up with different numbers. What's an ambulatory health clinic? I don't know. I don't know the exact definition. The definition we're using is it provides some medical care on site. But we do have a facility that only has a nurse, doesn't even have a nurse practitioner, and we're counting that as an ambulatory clinic. But at least we have 27 clinics that offer medical, dental, pharmacy, all the major things. I mentioned before we have 3 urban programs, one in Baltimore, one in Boston, and one in New York City. I thought you were going to put in scenic pictures. These are just different pictures of us working. Hey, that's me for the hygiene students. That's me applying fluoride. Ignore the infection control in that because this is in a quick setting to take a picture. I can't even see what some of these pictures are. That's some of John's graphs. John graphs everything. So I put this slide in here. This is actually a slide from about 3 or 4 years ago, the future of healthcare in the U.S. This is some of the things that were being envisioned then that are coming to fruition now. The old model was you have a primary care provider and everything centered around that. Now what's happening, and the Indian Health Service does actually lead the way on some of these things, having some telemedicine, having mental health as standalone programs that don't rely on that primary care provider. Traditional medicine, which is in the Native American way, it's pretty unique to the Indian Health Service. Telehealth through examples like group dietitian therapy or nutritional counseling. But anyway, I'll just put this in there. I thought it was neat to see all the different directions healthcare is going in. As far as staff, the Indian Health Service has about 6,000 staff. The majority of the staff, about 3,000, are nurses. We have about 1,000 physicians. This shows only about 400 or 500 dentists, but it's more like 600. A little less than 1,000 pharmacists. And there are 3 different personnel systems. People that are in these positions, at least, they can come into the Indian Health Service as a direct hire from a tribe. A lot of our programs are managed by tribes, and even though they receive funding from the Indian Health Service. And then there's the Commission Corps, where we wear a uniform. I'm actually a member of the U.S. Public Health Service Commission Corps, one of the 7 uniformed services: Army, Air Force, Navy, Marines, all Department of Defense, Coast Guard, which is Department of Homeland Security, NOAA, the National Oceanic and Atmospheric Administration, and the U.S. Public Health Service. So we're all we're all uniformed services. There's also, so I'm Public Health Service assigned to the Indian Health Service. And then the other personnel system is the civil service system, which John is a civil servant. Here, besides the obvious health professionals, here's some of the different opportunities available in the Indian Health Service: statisticians, epidemiologists, public health administrators, finance people, accountants, environmental health, since we have an environmental health person, engineers, of course all your medical professionals, we have contracting officers, we have clerical staff, just about anyone. Now there is, I will tell you, in the hiring, preference is given to Native American candidates. It's it's a law. It's called the Indian Preference Act. So that is, and veterans get second choice, and then everybody else. So, if you apply for a position and a qualified Native American applies for the position, they would get the position over you. But, I mean, on a lot of the health professions especially, we just don't have a lot of qualified Native American applicants. Here's some different pictures, just scenes. This is a powwow with a Native American. This was actually held in Nashville. This is a picture I took. I don't know how well you can see this, but this was when I was out in Nevada. I was out there for 9 years, and this was my road in. So sometimes they didn't clear the road. That's, I think, Maine, a trip. New Mexico. I'm also the area dental officer, so I'm in charge. I mentioned the different areas. I'm the area dental officer for the Nashville area plus the Albuquerque area, which has programs in Colorado and New Mexico. And that's another New Mexico picture down in southern New Mexico. And that's the Smokies? Yes. Yeah. And that's it. So what I wanted to do now was, John and I talked about this. This is not rehearsed. We're going to have an impromptu discussion, question and answer between him and me. And then we're going to ask if you have questions. So pull up a chair. We've never done this, so. But I thought it would be a different format. You still have to look that way to talk to him. Yeah, and why don't you put on the microphone? Can you all see?
All right.
So the first thing is, as I mentioned, and as Mr. Baylor mentioned, John started off as an intern with the Indian Health Service. So can you go over what you did as an intern, what you learned, what the experience was like?
Sure. One of the things that one obvious experience is that I was actually here in Johnson City, and the Office of Public Health is located in Nashville. So one of my experiences was that long distance communication and teleworking, if you will. So that was one interesting experience and new to me. Also, I was fortunate enough to work on some projects that where I could use my education in my undergraduate and also my public health education. And during my MPH, I concentrated on several different specific areas. One being quality improvement, and the other telehealth. So I was fortunate enough to discuss these topics and with the area office, and they were able to find projects that what they were either already working on or wanted to work on, start working on. So I was able to take my knowledge from MPH program and then start applying that in the real world setting.
Okay, so I think everybody would like to know now so your MPH was in healthcare administration?
Health services admin. Yeah.
Okay. And so now you've worked for 2.5 years? Is that right?
3.
3, okay. So why don't you discuss what you do now and how that education here plays into how it laid the foundation?
Okay. So some of the things I'm working on now are kind of those administrative processes and issues that you'll run into. For example, hiring qualified candidates. We do a lot of work on trying to change that process and improve it. Work with some of the health clinics and how they provide care, how the patients come through their service, how they experience care, and how can we change that and improve that care. So I work in that type of setting with the clinics that are located, as you saw, throughout the South and Eastern U.S., and also actually at the area office level on specific processes within the office there.
That's good. I thought you were going to talk for another hour on that one. Well, let me tell you a little bit about the Office of Public Health. Mr. Baylor sort of gave it away in introducing me, but we have a clinical applications coordinator, someone that is in charge. We have an electronic health record. We don't call it an electronic medical record because it isn't just medical, it's everything. So this one person is in charge of teaching all the health staff at all 31 health centers about this, and actually working with the technical team to install this software and implement it in day-to-day practice. We have a chief pharmacist who is responsible for overseeing all the pharmacy operations in the clinics. We have an area behavioral health consultant who also that person oversees the psychologists, social workers, and even the alcohol and substance abuse counselors throughout the area. We have an area statistician who, how many of you have heard of the Government Performance and Results Act? Oh, great. Anyway, Al Gore, former VP Al Gore, he's been here, correct? So back when he was the vice president, he created standards for the government to meet each year. And this was actually a law, the Government Performance and Results Act. And the Indian Health Service, just like the FBI, just like probably not Homeland Security, but the other agencies that existed at the time, are all given performance standards to meet. And the Indian Health Service, the standards all relate to health, like decrease the prevalence of diabetes, increase the proportion of people that receive the flu vaccine. And there are 21 different indicators. But our area statistician oversees the monitoring and promotion of those indicators. And our area actually shines nationally in meeting these indicators every year. I think last year across the Indian Health Service, across there are 400, 500 clinics, only 9 of them met all 21 of those health indicators, and 5 of them came from our area, and we're one of 12 areas. And not the largest by number of Native Americans, for sure. We're one of the smallest. So that's that person. John is our Quality Improvement Coordinator, also known as the Process Map King. He's very good at analyzing processes and making recommendations for improvements. And of course, the actual improvement work, he is more of a facilitator, and the manager of that department or whatever is the one that has to follow through with it. Mr. Bailey already mentioned that I'm the area dental officer, so I oversee dental clinics. We have 27 dental programs in the Nashville area, and we have 21 in the Albuquerque area. And some of them are large, some of them are very small, 1 chair. But I think our largest has 16 chairs, so varying sizes. We have a chief nurse who obviously oversees nursing, but nursing's a little bit complicated because you have hospital nurses, you have ambulatory care nurses, and you have public health nurses that are out in the community. So it gets a little complicated. He also oversees our health promotion disease prevention program. How many of y'all have heard that term, health promotion disease prevention? See, I'd never heard the term until I got into the Indian Health Service. But anyway, he oversees that, basically prevention programs. Did I miss anybody?
Elder care.
Oh yeah, we have an elder care consultant, a physician that is responsible for elders and for physicians providing care to elders. And we have a chief medical officer, I forgot, need to mention, who oversees the medical components of all of our health clinics. So that's who we are. What questions do you have? Yes, sir.
I've got a question about the IHS in general. So something that you mentioned on one of the slides was that there's a disparity between what's spent on the IHS. I think it's 2130 per capita versus 7784 per capita on CMS. Yeah, there we go. Is that it?
Yep.
Yeah. How is the IHS funded? It's part of the Department of Health and Human Services, which also CMS is a part of, right?
Correct.
We're paying into a trust fund that comes out of our paycheck every time. How is the IHS funded?
So the Department of Health and Human Services, this is just one of those budget line items under the Department of Health and Human Services. So when there's all this political wrangling, the Indian Health Service gets less money usually. But that's how we're funded. But we're funded at about 50% of the need that we have. And every year, our director, who again is a presidential appointee, develops. Actually, we're 3 years out, so we're already doing 3 years from now the budget formulation, and she presents a budget to the administration. The administration will trim a little bit, Congress will trim a whole lot, and that's what we're left with.
So how do the benefits work? Is it an insurance? Is it basically called the Indian Health Service? How do they access benefits to the card? How does that work?
So Native Americans have a I might have the date wrong, but I think it was 1924. The Bureau of Indian Affairs, which oversaw Native American health care and all Native American care, said we're going to do a tribal enrollment or look at the tribal rolls, and that is the basis for who's Native American and who's not still today. If they can prove ancestry back to that 1924 roll of whatever tribe, then they're considered Native American. And the Bureau of Indian Affairs, so there's two ways, if they're a direct member of a tribe, they'll have a tribal enrollment card. If they can prove Native American ancestry, they can go through the Bureau of Indian Affairs and get what's called a Certificate of Degree of Indian Blood card, or CDIB card, and they can present that to the clinic to get health care. You have to understand that the health care provided in the majority of our clinics, remember the majority of them are ambulatory health care facilities without specialists, means that they won't get specialty care by going to that clinic. There's some really convoluted rules on getting specialty care, and I won't go into all that, but we do have a separate pot of money to refer patients out to specialists for different procedures. And so sometimes those are approved and sometimes they're not. Does that sort of answer your question?
Yes.
Yes, ma'am.
As far as internships go, are they mostly at the master's level, or do you have some available for undergraduates as well?
We took our first undergraduate. John was the preceptor. Why don't you talk about that?
Right. We took 2 interns. I guess it was just last fall.
Yeah, it's been a year,
Or maybe spring. One an MPH student and one undergraduate, and so that they worked on different projects and all. So we do accept undergraduate students as interns through the field experience, right? Is it still called field experience?
And I'll say this about our interns. I think we've hosted 6, it may be 7, but our first intern, the whole reason ETSU fell in our lap or vice versa was that one of your former classmates was a Native American, and her mother worked with me. And she asked about the internship, and I said, East Tennessee, I've never heard of it, but I met Mr. Baylor, and we said, yeah, we'll host her, and she did an outstanding job, really made ETSU look great, and right now she is a clinical applications coordinator at the local level at Cherokee Indian Hospital. So that's a huge health system that serves 15,000 Native Americans, which is large by our standards at least. And she's in charge of the electronic health record still. So, but we've had five or six since then, and they've all worked out really well.
Have all of those been, I think John, you said you did yours remotely? Are most of those, or did you live in Nashville when you did the internship?
No, I was here in Johnson City. The The two previous interns were in Nashville, so they were able to work out of the office most or all of the time.
It's half and half. I mean, like the first intern lived in or right outside Nashville, and so she worked in the office. The next 2 or 3 worked remotely. John worked remotely for the most part. He came in a couple
times. Right.
And then these last 2, well, one of them lived in Nashville. The other one bought a place or bought an apartment or something.
Rented a place.
Just to do the internship, which we don't ask that. She did it. Yes, sir.
I was just reviewing something. You guys mentioned the accidental deaths or disproportionate cause of mortality among Native Americans and Alaskan Natives. Now, the Centers for Disease Control reports that in 2010, drug overdoses actually overtook motor vehicle accidents as the lead cause of accidental death nationwide, and that being Native American or Alaskan Native is an independent risk factor for mortality from drug overdose. What is IHS doing to help combat this trend among Native Americans and Alaskan Natives?
Well, about 5 years ago, so one of the growing drug trends is methamphetamine abuse, and it's no different in Native Americans than it is in the general U.S. population. So 5 years ago, the Indian Health Service created and they tied it with suicide prevention because that's where the money was. They created an initiative called the Meth and Suicide Prevention Initiative, or MSPI. And that's been going on for 5 years, and the goal of that was to reduce the diagnosis of meth use and decrease suicides or suicide ideations. And the biggest problem we have with that, are any of y'all coders? ICD-9 coders. The biggest problem is there doesn't seem to be a specific code for meth use. It's like drugs, which could be anything. So, it's been really hard to track that, but we think that's making a difference. Their tribes applied for funding to carry out programs, and it involves not just health from the health front, but social things to creating more after-school activities for kids, creating more social groups for adults, that type of thing.
Elijah, do you intend to fix that?
Maybe. I think so. I think it will have a specific meth code. But the suicide problem, getting data on suicides is really touchy. There's a cultural, I don't even think it's a Native American thing. I think it's, there's still some shame in reporting that. It's, there's all these steps of suicidal ideation, suicide attempt, and then of course the suicide. And, there's some communication breakdowns when there's a suicide. It's never a report back to a health clinic, But even, getting the precursors to that in a health system, in a code, is hard to get unless family members report it, Other questions?
So on your last slide, you had 297 openings. Is that current? Is that Nashville area only? Is
that came from USA Jobs, which is the central system where you look up any federal position. So that came directly from that. So that's nationally.
But for IHS specific?
For IHS specific.
At the current time?
Correct.
This is my experience with Dr. Hicks and the Indian Health Service came about just a few years ago. I had never heard of it either. And all I thought was, why didn't I know about this 30 years ago? I mean, it is just it is just everything that, anyone would want to do in the arena of public health is available through your office, really. And all of our concentrations are represented. Environmental health is represented, engineering is represented, finance and those sorts of career paths are represented. I'm delighted to see that John went down the quality improvement pathway. While John was working remotely doing his internship, he was also still working here as a graduate assistant. So multitasking is right up your alley, isn't it? So I really hope you will look at the Indian Health Service and the U.S. Public Health Service in general, because it is really just an area that seems to get overlooked, especially in our environment where we look at health systems or public health departments. This is just a whole world to itself and has everything to offer. And you can go down the commission services pathway or the civilian service pathway, which is either one of your choices. So.
And now's a great time. What we've seen is, as the economy took a downturn, more and more people came in. Now that the economy is getting good, everybody's leaving. Because money. You don't get into public health for money. If any of you think that public health pays, you're in the wrong profession. Okay, it really doesn't. You go into it for the same reason people go into Peace Corps. You want to serve the greater good of people. You have to go in altruistically. That's what it's about. And yes, there's some good financial rewards if you stay in. But so the point was that now that the economy is getting better, there will be more opportunities in the Indian Health Service and everywhere in the U.S. Public Health Service.
So it's USA Jobs. Can you repeat that website where folks can find information, John, please?
USAjobs.com, I believe, or .gov. I believe both would take you there.
And you apply online through usajobs.gov?
Correct. It is an online application process.
You can just type in what kind of field you're looking at, and it'll give you all the positions across the federal government, actually.
Yeah, you can narrow it down by agency, like I said, profession or concentration. Yeah.
Internships, should we go through USA Jobs, or is there a federal website we should look at?
Neither.
Go through
Mr. Baylor.
And I have to say that kind of maybe the take-home message for you is to take your field experience seriously and bring your ideas and things that you really want to focus on in a career, bring that to the preceptor, and they can organize a good internship or field experience for you. So take it seriously, bring your ideas to the preceptor, and it'll be worthwhile.
And one good thing about John is your bachelor's was in physical education, right?
Exercise science, similarly, yeah.
And your master's was in health services administration.
Right.
And now he's working in the Indian Health Service, and he's been cross-trained or getting cross-trained in all the statistical work that really he wouldn't have learned anywhere else. He's going to probably get cross-trained in multiple areas. That's what a public health system will do. And I don't think it's just our system. I think all of them will do that. A lot of cross-training, so you'll gain a lot of knowledge in a lot of different areas. And I don't want to leave out environmental health since somebody came up and talked to me. I forgot your name.
Kurt Meyer.
So we do have environmental health officers that go out. In our area, it's really good because our environmental health officers go out to the casinos and do inspections of the food and stuff like that. They also do health clinic inspections, X-ray certification, calibration of the X-ray machine, and a whole lot more. So environmental health, which of course is the foundation of public health,
It's a different process
is a
than
big
just
part
going
of our
through you.
program too. Just not part of the Office of Public Health where we're at. We're just into the healthcare part. Any other questions? Yes, ma'am.
As far as dental hygiene goes, because we're in a dental hygiene program here, you talked about how you have the largest sealant program. Is there a focus on disease prevention? And so are there many dental hygiene physicians instead of just dentists because the focus is on disease prevention?
Yes,
Okay.
there are. What should I tell you? Are you considering going into private practice at all?
Well, not really. We're like the road ones who are like, that doesn't sound like something we'd like to do. So this is something that our rural health professor talked to us about, and so he encouraged us to go to this. And this sounds more like something, the community health, which is definitely the path we're wanting to go instead of the private practice.
Yeah, I would say in our clinics across the country, really, dental hygienists probably spend 60% of their time in the clinic. But it's not like private practice where you're doing cleanings all day long and that's it. You're doing a lot of education in the clinic. You're doing a lot of patient management. One great thing about our system is we have all these software programs where you manage patients. People don't fall off recalls or anything like that. But the other 40% of your time, you're out in the community doing prevention programs. John mentioned our early childhood caries program, or preventing tooth decay in young children. That's requiring us to work with public health nurses for 0 to 2-year-olds that don't typically come to the dentist, and working with early Head Start and Head Start, going out into schools and doing screenings and sealants and fluoride varnish, teaching others to do fluoride varnish. We have a lot of liberties in that, if you in private practice try to go get a dental assistant to do a cleaning or a fluoride varnish, the state board would go crazy. But in public health, especially in the Indian health system, if you're on a reservation, you can just about train anybody to do anything, as long as it's safe, So we have, Head Start teachers applying fluoride varnish.
Which is great.
Yeah.
Is that what you wanted to hear? Yeah, there you go, there you go. The Indian Health Service, sort of, to me at least, sort of seems like a small entity. But there have been many things I learned from you that they really were way ahead of it. We were talking about the electronic health record. Well, how long has that been in play with y'all?
15 years.
See, way ahead of the curve in the commercial side of it now, and still wrestling with it for 15 years now. And so a lot of progressive things do happen indeed there. And they have the freedom to be able to do those sorts of things without quite so much red tape.
Fluoride varnish is another. It was introduced in 1964, and the Indian Health Service, we were doing fluoride varnish back in the late 90s. And, just in the last 2 or 3 years, have private practice dentists started doing it. And we were doing dental sealants on primary teeth, baby teeth, long before insurances decided they'd start paying for it. We did it because it was the right thing to do. Now that insurances are paying it, all these dentists out in private practice say, "Oh, we need to seal your baby teeth," but they wouldn't do it unless the insurance paid.
But this is, interestingly, this is true in several regards. There is a perception often in the communities that the private sector, because of competitive and other factors, is always ahead, I guess, of the government sector. And we've seen it with the IHS, we've seen it with the Veterans Administration, for example, that also has had comprehensive electronic health record for decades and been tracking the quality way ahead in terms of quality tracking and monitoring than the private sector. So at least within those two, agencies, the VA and the IHS, I think there are some very viable, tested models that can actually be applied, in the private sector. So hopefully over time we can have more of an exchange, between private and public, rather than silos the way we've had
Yeah.
before.
Well, and you look at, comparing our clinics to private practice clinics, look around just Johnson City and find out how many of the clinics are accredited by any accreditation agency. I'm not talking about the hospital. The hospital will be accredited. But look at your, clinics. Very few of them are going to be accredited. Look at our system, the Indian Health Service, and every federal ambulatory clinic is accredited by the Accreditation Association for Ambulatory Healthcare. Every hospital we have is accredited by Joint Commission. It's a requirement. So, and then the Institute for Healthcare Improvement, how many of you have heard of that?
IHI.
IHI. They're out of Boston, but they have they started 7 years ago with innovations in planned care for the Indian Health Service that later became improving patient care. But we were one of their, at the time they jumped in to help us, we were one of 12 health systems that they were assisting. Like the Mayo Clinic was one of the others. I mean, we were up there with the big dogs, so yeah, I think it's a really good system. I mean, there are a lot of problems. I'm not saying it's great. There are a lot of problems. We're underfunded. We aren't able to track and manage all patients because there is a transient nature to some of the Native Americans. And there are some generational issues such as alcohol and substance abuse, the diabetes, and things like that, you fight some battles and you lose some,
Dr. Hicks, would you mind telling, you may not want to, but you told me a couple of interesting anecdotes about some of the things that you've come across working with some of the tribal councils, I think along the way that you've had to interact with, and where there's governmental or governing conflict, or they want to run their own show. Is that right?
Yeah, well, I'm not sure which stories I told you.
It doesn't matter. Make up one. It's good. It's really.
Want me to make up an interesting?
Yeah, make up an interesting.
No, I mean, I'll just say that the Indian Health Service began in 1955. It took over for the Bureau of Indian Affairs, and originally all of these healthcare facilities were managed by the Indian Health Service. This is a very paternalistic, do what we say and that type of thing. Starting in the mid to late 80s, tribes, there's an act called the Indian Self-Determination Act. Yeah. And it gave Native American tribes the authority and power to, as sovereign nations, to take that funding from the Indian Health Service and manage their own health care for their programs. And the majority of programs now across the country are doing just that. So, it's important to realize that each Native American tribe is its own sovereign nation. So, it may be Pine Ridge Reservation may be located in South Dakota, but the Oglala Sioux are a sovereign nation, and when the president visits there, he has really no authority. It's nation-to-nation leader meeting. I don't know if that helps at all, but I thought it was interesting.
Obesity is a huge problem also in the Native American population, I guess, driving the diabetes prevalence.
Yeah, and it's a cycle with Native Americans. If you look at just the history, Native Americans were usually put on land that couldn't be cultivated. They were forced to take government commodities, which, if you know anything about government commodities, they're high in salt, fat, and sugar. So, so then they become obese and get diabetes, and the government says, wow, why is that happening? And the government was, at least partially responsible. But, I think there's been a lot of inroads. I think there's a lot of diabetes prevention things going on. There's a lot of obesity prevention, a lot more activities especially in the last 10 years or so, with young people especially.
Any other questions or comments before we let the men go? Well, just think about this for a second. They both drove from Nashville this morning. When they finish here, they're driving back to Nashville. That's a commitment, isn't it? That's 10 hours on the road to come up here and be with us for an hour and a half. So we can't thank you enough for that.